Hello, everybody, and good morning, good afternoon, good evening, wherever you are around the world and listening in. I'm your podcast host, Dr. Douglas Paull. I'm on faculty at Georgetown University School of Medicine in Washington, D.C. in the United States, and a member of the AMEE's Patient Safety Special Interest Group. Today's podcast focuses on medication safety, a topic that's aligned with the World Health Organization's slogan, Medication Without Harm. That we learned about on Patient Safety Day, September 17th, earlier in the year, as well as on a previous podcast from the AMEE Patient Safety Special Interest Group. Joining us today is pharmacist and patient safety leader, Mary Burkhardt. Mary serves as faculty at the University of Michigan's College of Pharmacy and Wayne State University College of Pharmacy and Health Sciences in Michigan. She's won widespread recognition for her work, including awards from the Institute for Safe Medication Practices, and is an expert in the field of medication safety. Mary currently serves as a national pharmacy executive and program manager at the Veterans Health Administration's National Center for Patient Safety, where her team investigates and addresses medication safety events for one of the world's largest integrated healthcare systems. Welcome, Mary. How are you? And thanks for taking time to talk with us today.
I'm great, Doug. Thank you so much for inviting me today.
Well, Mary, I'm sure the audience is just interested how you became interested in patient safety and, for that matter, medication safety.
Good question. Well, I became interested in medication safety during pharmacy school when we were in one of the pharmacology classes, and I learned about preserved saline in infants, and it was causing toxicity because of the preservative, benzalkonium chloride. And at the time, my mother was a nursery nurse, and I came home and was all excited to talk to her about this. And I gave her the information, and she took it back to her hospital leaders and the nursing leaders, et cetera. And she managed to get that preserved saline switched to non-preserved saline for when they diluted the antibiotics for the babies. So that was my first medication safety project. And after that, as a young pharmacist, my nursing colleagues, the first time I was a supervisor, I was actually assistant director, and my nurse colleagues at a private sector hospital invited me to sit down at the table with them every month, and we reviewed all the medication error reports.
Well, that's intriguing, Mary. Can you tell us a little more about your journey during the patient safety movement or over the past several decades? Any role models, mentors, or organizations that may have influenced your personal professional growth?
Well, I was an early adopter since I worked with enlightened pharmacists and leaders in nursing. It never really, I guess, and in medicine also, it never really was the tense situation that you see, at least in this first hospital environment. And we had engaged hospital leadership, and they were focused on patient safety before the IOM report. In fact, I remember sitting on my deck in 1994, there was the July 4th or 5th issue of the JAMA magazine that my ICU intensivist had handed to me. And he basically said, look, other people are doing what we're doing. And that was Lucian Leap's article and Dave Bates and that. And that we had a medication error reporting program. We had a drug reaction reporting program. And we also had clinical pharmacy monitoring that was overseen by the Pharmacy and Therapeutics Committee that governs the medication use in the hospital. So that's where it started. And then when I came to the safety center for the VA, the Veterans Administration, I knew a lot about medication use systems, but not about safety science, because who taught this? You didn't have this in school. So I learned about human factors from Dr. John Gosby, who was a NASA employee. He worked in the space agency, but he was an MD with a master's in human factors, and his lovely wife, Laura Lynn Gosby, who was a traditionally trained human factors engineer. And she was my co-author on a book chapter on human factors engineering in the medication use process. She was lovely. God rest her soul. She passed away. So I also took the systems engineering for patient safety. It was called SEIPS, SEIPS. It was a course at the University of Wisconsin. It was during the summertime. It was, like summer school. It was really wonderful. And I most recently, believe it or not, I completed the American Society of Health System Pharmacists certificate program in medication safety, which was a little odd because some of the people that I had as residents were teaching it. So, but I thought, I got to go through and do this because I want to make sure I've checked all the boxes. So it was really well done. And now it's version 2 of that program. I got at the tail end of the first version 1. So who were my role models? I think early on, it was my mother who encouraged me to be a pharmacist. And she was a patient advocate and a wise woman. So later on, my preceptor pharmacists encouraged me to do a residency in hospital pharmacy, which we're sitting in the city. I'm sitting right in the shadow of the University of Michigan, which is the first place that had a hospital pharmacy residency. And early in my leadership roles in pharmacy, I was lucky to have a hospital administrator that I followed from one hospital to the other, and he was focused on patient safety and on ethical treatment of patients and employees. All the things that we talk about now, we had that, and I worked with him from 1985. So, and even though we didn't have money, and even though it was a really, really tough work environment, he was terrific. And to this day, we're still connected. And when I went to work at the VA, the Veterans Health Administration, at the National Center for Patient Safety, Dr. Jim Bajan, who is an astronaut, engineer, physician, marathon guy, pretty typical, overachiever, right? But he's a patient safety expert, and he became my role model in safety science. And also he was a great tactician, like what's the tactic to get there, the strategy and the tactics. So as I was a pharmacy leader, like an assistant director or director of pharmacy, all along my journey, because those medication safety issues come up a lot if you're a pharmacy leader, I relied heavily on support from the Institute for Safe Medication Practices, the ISMP in the United States, but I also am connected or have been connected with the Canadian ISMP, the version in Canada. So I consider the President Emeritus, Dr. Michael R. Cohen, as a long-term mentor and friend. He just recently retired. He still works on the newsletter. And he's been a terrific advocate for patient safety and medication safety, probably one of the most influential people I've ever met. And their new president and CEO, Dr. Rita Jew, who is a Philadelphia native, and she's back now in Philly. She is our newfound colleague and collaborator, and she's, comes into the job with lots of experience and enthusiasm. And I have worked for ISMP Canada as a consultant, and I helped them develop their failure mode and effect analysis. I worked on labeling and packaging projects for them. I've done root cause analysis training, and I provided medication safety conferences in parts of Canada. And I also went with them to Saudi Arabia for the first ever medication safety conference in the Middle East. So that was very cool. And we had a 3-day conference there, and it's grown. Now I see on LinkedIn all the cool things that the Arabian Peninsula countries are doing. Very cool.
Well, thank you for sharing that, Mary. It's What a fascinating journey. And your personal journey, at least to me, it almost seems to emulate in many ways the evolution of patient safety, that systems approach to AIR rather than the exclusive focus on individual performance, socio-technical environment and contributions that human factors engineering had, not only on your professional development, but on a deeper understanding of patient safety in general. And the value of patient engagement, I think that you that you learned very early from your mother. Now, if you had a word or two of advice for an audience member that's just starting their professional career in patient safety, or even specifically in medication safety, what might that advice consist of? One or two things that you, looking back, you'd say, try to include that, or that can be an accelerant to your professional growth.
Well, I think we're seeing more and more, because of the way healthcare has evolved, we're getting more and more vaccines. And I think the complexity of the vaccine process, you need a scorecard for that, right? Because like you've got different versions and different timing and different administration routes and different packaging. So we've had, a number of vaccine events, which have been pretty well publicized, but still. And then we had Paxlovid, the new drug that came out for coronavirus, and the way it was packaged, and it was confusing to people. So I think the lesson is, when you're in a hurry to get something to market, there are special safety ramifications, because people didn't have the time to get everything all understood, and people don't quite understand. Like there was trouble taking too many or too few tablets with the Paxlovid. So we do know that packaging was changed because many organizations did report their events. So that's a good thing. And then root cause analyses. I think if you look back, I always, whenever I give the class, I say, what are the big three? It's opiates, insulins, and anticoagulants. Those year in, year out, the most morbidity and mortality with the severe events. And when we do a search here, I look at this last 3 months of root cause analyses. Those are the usual trends. So many other types of events can be analyzed, but those three groups are most often in aggregate review, for example. And then we recently had an initiative, which interestingly, it had been pretty well publicized since 2014 or so, to remove the dispensing of vinca alkaloids, a specific kind of chemotherapy, in a syringe, because the syringe would come and it would be this little small item, and people see a syringe and then there's tubing, and then they can shoot that in the tubing. Well, the tubing for the central nervous system, if they've got a port into the brain, that it can go right in there, and it's a fatal, terrible medication error that should be eliminated. So what we did is we said, if you're sending that medication out, it has to be in a small bag, so that it would be, they say, what do they call it? Cognitive dissonance or whatever. It just doesn't seem to do right if you were trying to put it in somebody's catheter. So we did that, and we partnered also with the Department of Defense, who gives chemo, and we wrote up an alert for us at the VA, and they ended up taking our alert. And when we're working on combined pathways, or combined, they call them power plans, then we made sure that when those power plans came to us, that the syringes were not in there. So that was a win-win for both organizations.
It certainly was, Mary, and thanks for reminding us. There certainly have been multiple global reports of that very fatal patient safety events that you just described. Now, are we getting better as a country or in the world in the prevention of medication errors in general?
The most difficult part about medication safety is how difficult it is to measure, right? So more sites around the world implement automation, and that's pretty much always a good thing, like barcode drug administration or drug identification in the pharmacy, at the bedside, and the use of smart pumps, the pumps that have the logic in there to catch the doses, make sure that all the parameters are correct. So we know that some events like wrong drug can be trapped by those technologies. But the difficulty is that some automation can't trap other kinds of events, and it introduces new complexity. Or it may not catch 100% of the types. So for example, barcoding at the bedside doesn't always catch the wrong route because you barcode the drug, but there isn't a barcode tag on the right upper quadrant of your arm. So it doesn't have a scan for that. So you can, and we've seen it happen. You can be drawing up the drug, go walk to the patient's room and get distracted. And if you have the wrong device that you drew it up in and forget to take the needle off and want to give it orally, you can accidentally give it in the intravenous route. So that's an example. So BCMA, it has limits, but new therapies and new technologies also bring risk to patients. For example, in the days when most chemo was given intravenously and it was administered in an infusion clinic under very controlled circumstances, you knew that the patient got it, how much they got, if it was given in the clinic, and which drug was administered. But with new regimens, which are very patient-centric, like oral chemo, they depend on the patient. And they have to be able to afford the drug. In the United States, that's a pretty big issue. And it has to be that the patient complies with the regimen. If you, I don't feel like taking that today, well, there goes your chemo. You didn't get all your drug. And patients can take them at the wrong time, with or without food, in the wrong method. And if they don't keep the drug down, because patients get nauseated even with their oral medication, if they vomit the medication up, you don't know what they got, how much they actually got. So it has added complexity to the care of cancer. And the big difference, I think, in most outpatient events is that the patient or the caregiver is the last line of defense. In inpatient, you usually have either a nurse or a technician, some intermediary that is between the pharmacy and the administration of the drug. So there's an additional line of defense. But if the pharmacist gives it out in the community, it's right to the patient or to the family. So also, outpatient events are complicated by the receipt of medications from multiple healthcare organizations or systems. And there are hazards related to the medication profile, the medication record. So you have an electronic record and you come into the hospital and they pull in from the insurance companies what medications you're on. But if the logic isn't well done, you can pull in somebody's wrong medication. And unless you interview the patient and do a really thorough job, you can have the wrong med show up in their profile. So that's a challenge. And then there's always the consumption of over-the-counter drugs and supplements and nutraceutical type items that do affect the therapy.
Well, Mary, from your perspective, what are the barriers to address some of the gaps in medication safety that you've identified?
Well, I think some universal barriers. I mean, I've been a pharmacist a long time, and these are the same barriers we had when I was just out of school, which include the appropriate staffing. That's why the staffing is a fundamental. Safety culture and lack of leadership for safety improvement. I can't emphasize enough how the staff will work with you to improve safety, but you have to be the willing leader, and that doesn't always happen. And then we have this concept of disrespectful or disruptive behavior is an issue in some organizations. actually sufficient enough that Joint Commission put out new standards on it for January of 22, that you have to have a management plan for preventing disruptive behavior. So then the lack of technology and inadequate implementation of that technology and maintenance is a hazard in medication safety. To me, you're only as good as your clean drug file. If you have a drug file that's full of, defective entries, it's not safe. And people don't think of that in terms of, you want to keep the pharmacy clean, but you need to keep the drug file clean too. And you need to have decision support rules that work, fire at the right time. You need to keep up to date with the software. So there's a lot in the technology space as far as barriers.
So Mary, given the gaps that seem to, some of them that persist in medication safety, what types of medication errors seem to continue or persist?
Well, they run the gamut from wrong medication to wrong patient, wrong dose, wrong route, and so forth. There is a group, it's called the National Coordinating Council for Medication Error Reporting and Prevention, otherwise known as NCMERP, NCCMERP. They have a taxonomy, which we loosely follow, and I followed at multiple jobs, but it is a bit thin on the outpatient side because this was primarily developed to categorize inpatient medication errors. So when I was in the mail order space for a few years, there's no category for shipping a med to the wrong address. It's sort of identification, but not really, because the right identity is on the drug. It just goes to the wrong, it goes to your neighbor, so to speak. So, then there's the issue in large environments about patient misidentification being a constant concern. And this has been published. I remember seeing some lab results coming in the same kind of issue with patient authentication between outside records and the current record in your system. So because of this information exchange, which is great, we want this to be shared, but you can clean up your misidentified patient and then the patient comes back and the same misinformation can be imported again. So it can allow the same situation to recur.
Well, thanks, Mary. And in addition to some of the causes you noted previously, what are some of the specific root causes and contributing factors of these medication safety events, or some of these medication safety events?
Well, if I were to pick common themes or root causes and contributing factors, I would pick the following themes. I would think drug supply chain issues that have been going on at least 15 years. I remember I hadn't been in the acute care environment for a while. And my first couple months back, it seems like we were out of everything. It's very, very challenging. And these supply chain problems cause the introduction of new products that can linger after the supply shortage is rectified. So you have to train people on the new item, but when the old item comes back, you have to go get the new item so that you don't have it too confusing, so you need a pullback method or a retrieval, or, get the meds back if your supply chain is rectified. My personal, I don't want to say pet peeve, but my personal mission is about unit dose packaging of the medications. Because that leads to patient care area access to more product than necessary. For example, a multi-dose vial of insulin versus an insulin that's drawn up in the pharmacy. If you've got a U500 vial, that's 10,000 units of insulin. You don't get it, there's almost no coming back from getting that much insulin by accident. But if you've only got a fixed amount, that's much safer for the most part. So it also keeps the bedside nurse from having to measure and calculate, because we know that our colleagues in nursing are often the most distracted professionals in healthcare. So another thing is organizational oversight of care processes. So one thing we've done recently is try to reduce variation in practice by looking at what we're doing, such as anticoagulation, diabetes, and pain management. Now, those three committees, they match directly up with the top drug categories that cause harm. And there are other reasons you would want to do that anyway, because it is good to have very regimented and standardized approach to these kinds of diseases. And those committees can look at adverse events, they can recommend improvement, they can help with standardization, and they can help tweak the approach to disease treatment. So the bedside staff and the pharmacy have some order and context to what otherwise could be chaos. So either maybe you're not going to use sliding scale insulin anymore, you're going to do the meal coverage and have a different approach. And then another one that's been out there for years, but we've made great strides in, is lack of pharmacists to clinically monitor the drugs and for general dispensing activities and order checking. So it's problematic during off tours, smaller hospitals, and rural sites. The good news is if you can do something electronic, that can be helpful. So we tend to cover the small hospitals with the bigger midnight, the bigger hospitals that have midnight pharmacy. And then dispensing by non-pharmacists. Rather than having patients present to the pharmacy to get their medication, sometimes the emergency department or other clinics, it's not just emergency department, but that they've been known to have their provider dispense the products. And that's good as long as all the stuff that the pharmacist does, the counseling and the appropriate labeling. So the double check and counseling provided by the pharmacist is often missing.
Well, Mary, this is fascinating, and it gets me thinking about the 5 whys, or an additional why to some of the root causes and contributing factors. And one has to wonder, why isn't unit dose packaging a universal standard around the globe? Or where do these drug supply issues come from that even predated the pandemic? What's the cause of those? Your thoughts?
Well, unit dose packaging has been a professional practice standard in the United States since I have been a pharmacist, and that's been a long time. So it's at least 4 decades. But the problem is, you may purchase it in a gallon, a 4-ounce bottle, and then you have to take it and break the liquids down. So I would say it's a worse problem for liquids. Most tablets are pretty well settled, but sometimes people don't go around the pharmacy and go, hey, I can buy that already pre-made. What the heck? And so honestly, in my last chief job, I sent a pharmacist around the pharmacy, and why are we sending this in a 4-ounce bottle? Or, this comes in this kind of packaging. Why aren't we getting the smallest? So we did that. And then as far as drug supply issues, many of them are, part of it is globalization, right? And we are 10 countries away from the active pharmaceutical ingredient. So if something happens with the weather or political unrest, now we're stuck away from the source of the drugs. That's number one. Number two is, because of the manufacturing being less expensive overseas, we've tended to do that sometimes, where we have the production in other countries, especially, it can be brand name, but it's also generic drugs sometimes. And the other thing is, there is low amount of money for products that are expensive to make and low margin. So the generic injectables has been really difficult. It's so difficult that, fortunately, a really good thing we just did, the Department of Veterans Affairs, the Department of Defense, University Health Consortium, that a big
Yes.
group of hospitals in the United
Mhm.
States, Ascension Health, and there's a few others. They formed a big conglomerate to fund its own generic drug manufacturing. It's called Civica. And we bought a manufacturing company and they hired an executive, and Civica is providing, like magnesium sulfate and potassium chloride. These things aren't so exciting to make, but they're life-saving. And, there's not a lot of margin on those products. So they're doing that. And it's been very cool. It's one of the most exciting things we've done to improve the supply chain.
That is exciting, Mary. Now, I think we've really, this has been a wonderful and fairly comprehensive review of the background of medication safety, the infrastructure necessary for medication safety and the modern technology, some of the types of events that persist, as well as their root causes, contributing factors. And now for I know the audience members go, okay, what can we do about all of this? In other words, let's talk about possible solutions or improvements to overall medication safety for just a moment. Now, understand you've developed a medication safety pyramid. Could you describe this concept or this conceptual framework to our audience?
Yes. So I was working with a colleague from ISMP Canada, and we had gone to visit a hospital, and we had given some recommendation. It was a lot of recommendations. They implemented all the hard stuff, and the simple one item that's a 20-minute job never got done. And we couldn't, why? So we figured out that people like working on the exciting new stuff that they can develop, and that is like breaking news and cool stuff, but some of the fundamentals aren't the most fun things to work on. So that's where we came up with the idea of a medication safety pyramid. So at the bottom, this bottom row where it says storage, security, drug supply chain, those are paving the road. You got to have the basics down. One time somebody said to me, if you were a clinical dietitian, you wouldn't be talking about all these fancy diets if the food didn't show up, because it doesn't make any sense, right? You're doing the high level stuff, but the basics don't work. So when I work with my staff in the hospital, I say, well, the pharmacy's got to be clean. We have to have the drugs locked. There's physical environment, there's drug related factors, and there's people. You have to have core staffing, and you have to have professional competency of the staff that work with you. So once you get those done, then you can go up to the little fancier things. You can do like dispensing things and fancier packaging and labeling, get a nicer machine, get something that does barcodes, work on timeliness, and then once you get those things improved, you can go up to the next level, and it gets progressed. As you go up the pyramid, it gets more cognitively difficult. The bottom ones are bottom up things, and the ones at the top are the top down, that from a cognitive processing, they're more difficult, like the clinical outcomes and genomics and all the fancy stuff. But you shouldn't be working on genomics if you got a hole in the pharmacy wall and people are taken off with the drugs, or the patients don't get the right drug. So what I tried to do this is like a Maslow's needs hierarchy. It's kind of similar. And then the evolution gets more complex, and it gets a little bit fancier as you go up the pyramid. But at least you can give the supervisors or the staff a place to start. Like what are the holes in, the processes that we have? For example, just to give you a case, I remember having built a brand new USP 797 clean room, and we've got all this stuff, and I've got media fill, and I put booties on and all this, and I walk into the room and there's a soda pop in the refrigerator. And so that's not clean environment. So we had to fix that problem and make sure people understood, so once you got the environment down, then you could make sure that you have the way the drugs are used are improved. And then you work more closely with outside, like the medical staff and the nursing staff, to get to the best use of the medication. So at the top of the pyramid, you might have an anticoagulation service managed by pharmacists, or a team to look at nutrition, because we know that patient outcomes are better in by teamwork, right? But if you can't get a clean TPN to the patient, a nutrition solution, and it's full of fungus or whatever, you're not doing anybody any favors by skipping the bottom rows. So it was based on fundamentals, and kind of like building blocks.
Well, thanks a lot, Mary, for sharing the medication safety pyramid. I think our audience members are going to be wanting to take another look at the pyramid and see how perhaps they can use that framework or that model in their own medication safety efforts. Time has gone by so quickly. We want to thank you, Mary, for a fascinating discussion. This has just been just an insightful conversation. And again, also would like to thank everybody listening around the world to the podcast, and for all their continued efforts to improve patient care and to teach others. And we hope you'll consider joining AMEE's Patient Safety Special Interest Group in the future. With that, and on behalf of Mary Burkhardt and myself, Doug Paull, we'd like to say thank you for joining us. Goodbye now.